Hello, everybody. This is a recording of the second part of our lectures on blood. You have seen the first part of blood. We have covered red blood cells. We have covered plasma components. And now we are moving on to the rest of the blood components. As you'll see, we'll be looking at two large events in the life of blood as a tissue, which is blood clotting, and then we'll talk about blood groups as well. So let me go to the slide sharing, and let's get started on this second part of the blood lecture. Let's make this full screen right. Yeah, I'm going to turn this to a smaller chunk here. So after exploring where red blood cells come from, how they are recycled, we are going to say very little about white blood cells. We'll be seeing actually quite more in the lab. Here in lecture, most of the white blood cell properties will be explored in connection with the immune system. Let's take a look at a few properties of white blood cells that make them totally different from red blood cells. Well, it's not even on this slide, but under the microscope, they are highly recognizable. They stain purple, most of them. White blood cells have nuclei, so they are normal cells, and white blood cells can also move. They don't just rely on the bloodstream to move them in a particular way like red blood cells do. White blood cells have their own mind, and as you see here right in the middle, white blood cells have the ability to leave the bloodstream, meaning they push the endothelial cells apart inside the blood vessel and scoot out of the blood vessel. This is called emigration. Now, why would a white blood cell emigrate from a bloodstream? Because white blood cells can be attracted to pathogens, tissue injury, and they follow those tissue debris molecules like a bloodhound, and that ability to follow a chemical trail is called chemotaxis. And when white blood cells take a scent of, again, pathogen infection or tissue injury, they emigrate from the blood vessels and go to the site of injury. Some white blood cells are extremely efficient phagocytes, means that they can gobble down, they can endocytose, or more specifically phagocytose, tissue debris, pathogens. A huge part of our immune system actually depends on these neutrophils, macrophages. So again, we'll be seeing a lot more about these cells in the immune chapter. This image will be really helpful because you'll be seeing these cells under the microscope in the lab. The color is totally artificial. It's coming from staining. So normally they would be white, but we have white blood cells with granules, and you see the eosinophil, basophil, neutrophil, all the phils have granules. They called granulocytes. And we do have the agranular leukocytes, monocytes, and the lymphocytes. So this is the classification based on appearance. You can also see the nucleus. It looks kind of weird by shape. You'll be seeing this in lecture. I'm sorry, you'll be seeing this in lab quite a bit. Let's say a few words about platelets. Platelets are also made by the red bone marrow. If you go back to the hemopoiesis slide, you'll see that the cells, megakaryocytes, are responsible for making platelets. Megakaryocytes are huge cells that split into small fragments at the edges. And those small fragments, those little bags of plasma membrane filled with cytoplasm, that is what we call a platelet. Platelets have short lifespan, and they are removed from the bloodstream, just like red blood cells, through the action of liver and spleen. In a few minutes, we'll come back to the platelets because they have a tremendously important role in blood clotting, stopping bleeding. And so we will dive into the functional aspects of the platelets. During regular lecture, I said a few words about stem cell transplant, bone marrow transplantation. And with the stem cell, we are talking about those stem cells that are in the red bone marrow and capable of making all kinds of blood cells. So I'm not going to say more about this. Bone marrow transplantation, very significant role in curing many kinds of childhood leukemias, and sometimes they are used in adults with somewhat less success in cases such as sickle cell anemia. I want to say maybe a few words about cord blood transplant. So sometimes parents are asked if they want to freeze the placenta and cord blood after giving birth. What could be the point of that? Well, the placenta and the cord blood is full of stem cells. Stem cells not only that can serve the job of making new blood cells, but stem cells of many other types. So this could be a resource later on in case that newborn child later on develops a disorder and a stem cell transplant would be desired. These stem cells from stored cord blood and placenta might be grown in culture to help this kid who might get into some kind of a medical trouble later on. It's much less tested than the bone marrow transplant. Nonetheless, I just want to say a few words about that. Again, stem cells are the valuable part of that cord blood or placenta. So let's switch over to this first huge event in the life of the blood, which is an emergency. Blood volume is dropping because of bleeding. And bleeding just means that blood vessels are damaged and they no longer confine the blood. In plain English, there's a leak somewhere, or leaks. This needs to be stopped. We have a limited blood supply. Replacement is relatively slow. So if we are losing a pint of blood a minute, we don't have the blood forming capacity to replace that. So the only solution for bleeding and maintaining homeostasis is to stop that bleeding. Now that is called hemostasis. In our household, if there's a leaking pipe, that leaking pipe can be fixed just by putting some kind of sealant on the outside, or maybe a tape, or welding it if it's a copper pipe. In our body, this works totally opposite. We are putting a plug, a band-aid, if you will, a clot, as we'll be calling it, from the inside. So here's where the components of blood are tremendously important. The blood components have these pieces of band-aid that can be assembled, turned into a functional band-aid to stop that bleeding from the inside. And so this is why we talk about blood clotting in connection with the blood and not with blood vessels. There are three main reactions here that we consider as a reaction to injury to blood vessels. And the first one is vascular spasm. So when a blood vessel is injured, whether it's crushed or cut, the smooth muscles react to tissue debris, internal contents of cells that are floating all around because cells are damaged, blasted open. So smooth muscles react by very quick contraction. So imagine the wall of the blood vessel, just like that circular set of smooth muscles in the iris. When you make them contract, the blood vessel diameter, just like the pupil, will narrow, and that is vascular spasm, vasoconstriction is taking place. In a major blood vessel, like a major artery, this is of no use because tremendous amount of blood is still getting lost. But much smaller blood vessels, this is an effective way to slow blood loss. If you want to stop blood loss, we need to plug that hole. And so here comes our favorite formed elements, the platelets. The platelets are swimming around in the blood. In this process, the platelets will become sticky suddenly when there is an injury to a blood vessel or bleeding takes place, and these sticky platelets aggregate into a plug. There are several steps to this, so let's take a look at the platelet adhesion, release reaction, and platelet aggregation. Here's our model. You can see the blood vessel internal lining. These yellow cells are the endothelial cells. You see red blood cells, you see the platelets. And the platelets are filled with all kinds of very useful components. We'll talk about them in a minute. So, and now we are seeing an injury down here at the bottom. How will the platelets know that there's a damage to a blood vessel? The key to this is that during physical injury to the blood vessel wall, collagen fibers will be exposed right here. Endothelial cells are either damaged, they're pushed away, or destroyed in this injury process. And collagen fibers are now facing the platelets. When a platelet contacts collagen fiber, the platelet changes completely from a little disc-shaped structure to a Velcro-like sticky small formed element. And that allows the platelet to stick to the collagen fibers and also stick to each other eventually. But this is where it all starts. So this is the trigger exposing collagen fibers. And these collagen fibers were covered up previously by the endothelial cells before injury. So now platelets are adhesive, they're sticky. Here you see the step when platelets aggregate together. You see the platelets are sticking to the blood vessel wall and to each other, and they are releasing their content. So the content of the platelets will make neighboring free-floating platelets sticky as well. And as a consequence, those sticky platelets keep running into each other and forming a plug. So releasing the content of the platelets recruits platelets by activating them, making them sticky. So this is where the platelet release reaction is important. We are making a much larger block here. Excuse me. So platelets are now sticking to each other. They aggregate to form a single mass. And as a last step in this aggregation, you see these lines here, these threads. They are called a protein fibrin, and we have to tie down this platelet plug. Otherwise, the blood flow that's continuing in this blood vessel, that blood flow would just blow this plug off of this injured location. So we need to tie this down. We need to make it more sturdy by using these fibrin threads that you see crisscross this entire plug. In the meantime, please notice that the injury is starting to heal. So probably in a week's time, this plug will become totally unnecessary. But until then, the platelet plug prevents the leakage of plasma and formed elements. So with the platelet aggregation, we achieve this construction of a band-aid, a platelet plug from the inside of the blood vessel. Where these fibrin threads come from, this is the next set of events. And so let's take a look at what is called a clot formation. So blood clotting is the process by which fibrin, sticky fibers, are created inside our bloodstream. Normally, without clotting, we have fibrinogen protein swimming in our plasma, and at a signal, fibrin will be created from those fibrinogen. In this process, we are seeing enzymes that are made by the liver. These are called clotting factors. These are protein digesting enzymes. They are chopping up neighboring proteins. Here's the requirement for calcium. So we need to have clotting factors and calcium. Because this is a series of events, just like pushing a set of dominoes over, we call this a cascade, clotting cascade. How do we start this clotting cascade? Take a look at way down here. Fibrinogen is swimming in our plasma in large amounts. Nothing to it. It's not sticky. But then let's take a look at the extrinsic pathway. Here comes a trauma that crushes this blood vessel. And the crushed cells on the outside of the blood vessel release this chemical called tissue factor. Tissue factor seeps into the blood through this crushed injury surface. And inside the blood, here's one clotting factor, number 10, and another clotting factor, number 5, will be brought together with calcium to form prothrombinase. So these combined factors form prothrombinase. We'll be seeing a little later that this prothrombinase is going to chop prothrombin into two pieces, pro and thrombin, and then thrombin is going to chop fibrinogen into two pieces, fibrin and ogen. This is the extrinsic pathway when tissue factor is the trigger. Let's take a look at the other side of this illustration, intrinsic pathway. So intrinsic pathway is triggered from inside when the endothelium, the lining of the blood vessel, come in contact with the activated platelets. The released phospholipids from platelets will be the activating factor. And here we are first interacting with factor 12, and then factor 12 activation comes with the activation of 10 and 5. And so with calcium, yet again, now from a slightly different starting point, we are creating prothrombinase. So whether you are reacting to a damage or crushed injury to a blood vessel, or you are reacting to factors released by activated platelets, eventually prothrombinase, and very, very quickly, in a matter of seconds, prothrombinase will form. Now, with the intrinsic pathway, it takes a little more time because we have to wait for the platelet activation to take place. For the extrinsic pathway, as soon as injury occurred, this tissue factor is already doing the activation. So what happens after prothrombinase is made? And we say, hooray, we're still very far from fibrin. So prothrombinase, as I mentioned before, again needs calcium to chop factor number 2 prothrombin into 2 parts. The thrombin part is yet another active clotting factor, and the thrombin enzyme is going to now chop fibrinogen into 2 pieces. The fibrin piece is a rope-like molecule with sticky ends, and thousands and thousands of fibrin strands will, fibrin molecules will form the fibrin threads. The fibrin threads are sticky, and so they stick to white blood cells, red blood cells, platelets in this forming platelet plug, and eventually they form this mass of cells glued together, tied down together in a sticky mass, which we call the blood clot. We do need both the platelet plug formation and the fibrin threads together. Without platelet plug formation, the fibrin threads are just ineffective. And without fibrin threads, the platelet plug is too unstable. We'll be talking about disorders called hemophilia, where some of these clotting factors are missing. In hemophiliac individuals, platelet plug formation goes on perfectly, except the platelet plug is not tied down, not stabilized, and there's still considerable bleeding that happens as a consequence of hemophilia. So we need both the platelet plug and the fibrin threads. A little known role for vitamin K in this entire clotting. You didn't see the name vitamin K mentioned. That's because when factors 2, 7, 9, and 10 are made by the hepatocytes of the liver, vitamin K changes the structure of these factors to an active factor that is ready to play a role in these reactions. Without vitamin K, these factors are made, but they are just a lot more sluggish. Vitamin K is made by bacteria in the large intestine, or we consume this through eating green leafy vegetables. One advantage of knowing that vitamin K is needed, that we can block the chemical reaction vitamin K causes. And this is our first blood thinner here that we mentioned, warfarin or coumadin. So patients treated with these anticoagulants, blood thinners, will have much, much lower level of blood clot formation, because without vitamin K, these factors will be very sluggish, acting very slowly. So if in a clinical setting you want to avoid blood clot formation, anticoagulants are the pharmaceuticals of choice. And let's come to the end of the clotting process. We successfully sealed this leak. The blood vessel healed up underneath. And the question is, what are we going to do with this clot? It's sitting inside the blood vessel. So we do have clot degrading, clot busting mechanisms in our body. This is called a fibrinolytic system. It's called fibrinolytic because it will cut into small pieces those long, sticky fibrin threads. And once you cut the fibrin thread, the entire clot will fall apart, and they will be cleaned up by local macrophages or neutrophils. So this fibrinolytic system also helps to dissolve inappropriate clots. We do have inappropriate clot formation in our body 24/7, and it is thanks to this system that prevents clot formation in the middle of the bloodstream, where there's absolutely no use for it. And an undissolved clot in the middle of the bloodstream will be plugging up something eventually. If a clot gets into the brain, we'll have a stroke. If a clot blocks blood flow in the lungs, we have another disorder. If a blood clot blocks veins in the leg, we have deep vein thrombosis. So here is the protein that activates plasminogen, part of this fibrinolytic system. And the advantage of this tissue plasminogen activator, or TPA, is that in an individual who has a stroke, this could be infused into the patient, and TPA will perk up the patient's fibrinolytic system and can lead to the removal of a clot that's already lodged into the person's brain vasculature. So if this is applied within 4 to 6 hours after a stroke, a lot of the times patient recovery is very, very quick. The last item here that we need to look at is blood groups and blood types. So here we are talking about a condition, components of our body that are definitely in place, but there's no physiological role for them, at least not that we know of today. The reason why we mention these components is because during blood transfusion, these are the components that can make things go smoothly or make things go really, really bad. So blood types, as you see them listed here, type A, B, and O. This will be our focus, although there are many different blood groups. We are not going to touch on them. The RH group or RH blood types will come up in the lab. But outside of that, let's focus on this ABO blood types. So let's see how this could lead to any kind of trouble. So first, the components. Here's an individual with type A blood. When you look on the red blood cell surface, you see a kind of small glycolipid molecule, and this got the name A antigen. In the plasma of the same individual, there's an antibody, a sticky molecule that can stick to B antigens. This is the anti-B antibody. In this person, the anti-B antibody is not seeing a B antigen here, so the antibody swims by the red blood cell. There's no reaction. Everything's cool. Let's take a look at a type B individual. Now, on the red blood cell here, there is a different antigen, different small chemical structure. This is called B antigen. When we look in the blood and the plasma of this individual, we're seeing an antibody that would stick to A antigens. This is an anti-A antibody. In type AB blood, the red blood cell has both A and B antigens. but in the plasma, neither anti-A nor anti-B antibody. And when we look into a type O blood type person, the red blood cell doesn't have either A or B antigen, but in the plasma, we have both anti-A and anti-B antibodies. So let's take a look at how this natural stickiness of these antibodies can be a problem. And we're going to simulate here a botched transfusion. We're going to take donated blood from a type A individual and transfuse it into a type B recipient. So let's see what will happen. Let's take a look at the fate of the donated red blood cells. When this red blood cell enters the type B individual's bloodstream, the anti-A antibodies immediately recognize the A antigens, they will stick, and this red blood cell will be destroyed by the recipient's immune system. Even worse, because we transfuse full blood, the donated blood has anti-B antibodies, which will stick to the recipient's B antigens, and some of the recipient's original red blood cells will also be destroyed. So this is just leading to a diminished capacity to maintain life, not the advantages that we hope for a blood transfusion. Two more aspects of these blood types to mention. Let's take a look at first the type AB individual. In this individual, there's no attacking or sticky antibody. So into this individual, any red blood cell type can be transfused. So if you take B or A antigen-bearing red blood cells, you wash the plasma away, and you just transfuse rinsed red blood cells into this patient, it will not be attacked because there are no antibodies. So the type AB individuals are also used universal recipients because they can receive just red blood cells, not whole blood. They can receive red blood cells from any other blood type. The type O blood type has another unique property. A red blood cell has no A or B antigens. So you can take this red blood cell from donated type O blood, rinse it, and this red blood cell can be transfused into any of the other red blood cell because there's no antigen to be attacked on this red blood cell. So for that reason, the type O blood is called universal donor. I'm not going to say much about these two slides. I do want to mention here at the very end that there's a summary set of slides about different types of anemia. We mentioned disorders related to hemoglobin. We also mentioned the word hemophilia. Here's a little description of this related to blood clotting and missing clotting factors. And I also want to have, this is just an informational slide. In the lab, we will see blood smears coming from leukemia patient. And so leukemias tend to come with a huge overproduction of some white blood cells, leukocytes. Again, we'll be seeing this more in the lab. So let me get out of this sharing. Right. So thank you for listening to this lecture closing out the blood chapter. I'm going to be attaching it to the class shop. If you have any questions, please send me a message, and I'll see you guys in a few days.